We'll start off by saying this conference is accredited for CME by the Yale Medical School. There are no commercial sponsors of this conference. Disclosures were reviewed and no conflicts of interest were found. All right, it's my honor this morning to introduce Dr. Ellimoottil, who is the Director of Virtual Care for the University of Michigan Medical Group, the PI of the Telehealth Research Incubator Lab, and an Assistant Professor of Urology at the University of Michigan. As the Medical Director of Virtual Care, he oversees the strategy and implementation of virtual care services across all specialties, which completes approximately 400,000 virtual encounters per year. As the PI of the Telehealth Research Incubator Lab, he directs a portfolio of projects focused on optimizing the delivery of virtual care. Specifically, he studies the population-level impact of virtual care on access, costs, and quality of care in the Medicare population. His research is funded through an R1 grant from the Agency for Healthcare Research and Quality and the Michigan Health Endowment Fund. He's been invited to speak about virtual care in many private and public venues, including the U.S. Department of Health and Human Services, National Public Radio, and Freakonomics Radio. In addition to his research and administrative duties, he also has firsthand experience using virtual care with his own patients and is well-versed in the benefits and challenges of this mode of healthcare delivery. All right, we'll give it off to you. Thank you for coming.
Awesome. Thank you for that introduction, and thank you for the invitation to join you guys this morning to talk about a topic that I'm very passionate about, which is virtual care and telehealth. And so the title of this talk is The Current and Future State of Virtual Care in the United States. And, essentially what I'll be doing is talking about where virtual care is today, and then where I think it's going to be in the future, namely 2025. And I'll explain why. And, during this talk, I'm more than happy. I'm going to go through some content here, but I'm more than happy to stop. Periodically, I'll there's a lot of content, so I'll just kind of briefly stop and ask if there's any questions. You can put them in through the chat. More than happy to dig deeper into any particular subject, but if there isn't, I'll just keep, I'll keep rolling. And just before I get started, I want to just give you a little bit of background on me and how I first became interested in virtual care. And so I became interested in virtual care when I joined the faculty here at University of Michigan back in 2016. So as many of you probably see, this is a very common patient of mine, Susan. She's a 55-year-old elementary school teacher with recurrent kidney stones. And so back then, the way that I would monitor her is that I'd see her about every 6 months. Periodically, she'd need surgery for the stones, and then I would see her back for post-operative visits. And so my visits with her were pretty simple. I'd walk from room to room to room. I'd go inside her room, and we'd pull up her x-ray, look at her stone, and tell her whether we're going to do an operation or if we're going to keep monitoring. And so from her end, that visit wasn't as simple. So she's a teacher, so she would take the day off of school. She's coming from Saginaw, Michigan, so we have referrals from all over the state, just like you do. And so she would travel 1.5 hours each way for her trip. She would spend about 45 minutes in clinic, and then 15 minutes for that consultation. So all in all, she's spending about 4 hours for me to tell her that her stone looks stable and I'll see you in 6 months. And so that never really made a lot of sense to me. And I knew about virtual care and I knew it existed. And so it seemed like a great place to radically really change care and transform care for patients like Susan and many other patients that we see in urology that are similar to Susan. So back then I knew it just didn't quite make sense. And I understood that the thing that was holding it back was really, in addition to culture change, was also healthcare policy. And that's why I ended up devoting my entire career to studying virtual care. And so in addition to the clinical aspects of it, I helped pioneer the program at University of Michigan in our urology department, and then more recently became the medical director of virtual care. And as you heard in the introduction, essentially across all specialties, about 400,000 encounters that we do per year, developing the strategy for that. And then I'm a health services researcher, so I like to study the healthcare delivery system and healthcare policy. And so what a perfect place or perfect topic to study when it's a healthcare policy that's really holding back virtual care. So my research lab is focused on the population level impact of virtual care on healthcare spending, healthcare costs, and healthcare access. And ultimately, as a health services researcher, one of my biggest goals is to inform policy. And really, it's not just the research, it's all three of these lenses that helps me do that. And so my objective for you this morning is to use my clinical research and health system leadership experience to provide an overview of the history, the current trends, and then what I think, at least my opinion, of where the future of virtual care is going to go. And I'll have a very specific focus on healthcare policy as opposed to technology and so forth, although I will talk about some of the technologies that we're looking at near the end of the talk. So you may know or may not know that telehealth has actually been around for a very long time. It didn't start with the COVID pandemic. It's actually been reimbursed by the Medicare program since 2001, so more than 20 years. There was this restriction that kept and really hindered the growth of telehealth. It was called the originating site restriction. It's a geographic restriction that basically said that you cannot connect and do telehealth with a patient at home. That patient had to actually travel to a medical facility, and they can connect from that medical facility to your facility, but that medical facility also had to be in a rural area and a health professional shortage area. So that was the rule that sort of that was kept for virtual care and really kept virtual care from growing. And so it's just not practical with the way that we practice medicine. But there were some milestones, 2016, 19, 20, where some insurance organizations were starting to recognize that, hey, virtual care may be preferable for patients. This may be helpful for certain conditions. So they started to relax these geographic restrictions. So if you guys work at the VA, you know that the VA was well ahead of this. In 2019, the VA completed 2.6 million telehealth visits. Just like they were ahead with electronic medical records, they were actually ahead with virtual care too. Some states, in some states, the Medicare program was ahead of the Medicare program. They're not always tied together, and they were allowing patients to connect from home. Commercial payers like Blue Cross Blue Shield in the state of Michigan was also a little bit more forward thinking, and they allowed patients to connect from home since about 2016. And Medicare was starting to think about it. They didn't want to open the doors because they were worried about healthcare spending, but they did start to make some exceptions for certain conditions, like if you had a stroke, end-stage renal disease, if you were part of the Medicare Advantage plan, or part of these demonstration projects called alternative payment models, then there was a waiver in there for telehealth. But yet, even with all of this momentum prior to the pandemic, in February of 2020, a month before the pandemic, less than 1% of healthcare providers, less than 1% of of patients were using telehealth. And so all of that changed in March 2020. And so in March 2020, with the COVID-19 pandemic, there was a strong incentive for social distancing, both from patients and then from healthcare providers too. And healthcare providers needed to keep their doors open during this time period. So that's when telehealth really started to grow. And in order for it to grow, some of those restrictions that were placed on it before needed to be relaxed. And that's exactly what happened. So these are the 5 big policy changes that occurred that allowed telehealth to grow. One was that patients were allowed to connect from home now. You didn't need to be in a rural area and travel to a medical facility. You can connect from home. Providers were allowed to practice across state lines. That was just practical. We were reimbursed at the same as an in-office visit. And then patients had their co-payments waived, and then some of the privacy rules were also relaxed so that some common technologies could be used. And that's exactly, these are the big 5 things. They're tied to something called the National Public Health Emergency, which we're actually still in for COVID-19. And so because of these regulations, telehealth grew, and that's exactly what happened. So in our research lab, we use Medicare data, and we follow trends on a quarterly basis to sort of demonstrate what's happening with with telehealth use. And this is a figure from our research. And so this is a time trend from January 2019 all the way up to the end of December 2021. And these are outpatient encounters through telehealth and through in-person. So the bottom line is telehealth. And you can see that in early pandemic from March to July 2020 was really the spike in telehealth. It helped salvage that big drop in outpatient care that occurred early in the pandemic. And at that point, there was a peak. About 50% of healthcare encounters on an outpatient basis were being done through telehealth. And slowly from that peak, we started to go down. At this point in December, and also in our 2022 data, we see that about 1 in 10 healthcare encounters for Medicare patients is through telehealth right now, which is lower than it was at the peak, but much, much higher than it was prior to the pandemic. And for commercial payers, this is a bit higher. In our research, we're seeing that it's about 20%, so 1 in 5 for commercial payers, but still much higher than it was prior to the pandemic. And so recently there was a bit of a breath of relief. And so for many of us in the operations side, we were also always worried about these regulations coming back suddenly as soon as the public health emergency is declared to be over. Now, there was some cushion built in there, but for the most part, everything was kind of tied to this public health emergency. But on December 29th, about 20 days ago, when the president signed the year-end spending bill, you may have heard about this on the news. It's called the Omnibus Bill, which includes a lot of different provisions for a lot of different things. Swept into that were these telehealth provisions, the ones that were allowed during the public health emergency. And essentially the spending bill said that these are going to be extended for another 2 years. So that means 2 more years of coverage for telehealth to the end of December, December 31st, 2024, effectively 2025. And those are going to be held there even if the public health emergency goes away. So it's still not permanent, but it is extended for another 2 years, which gives us a little bit more of a concrete timeline in terms of building strategy. And so included in this is the removal of those geographic restrictions that I talked about, and then also coverage for phone calls, which I know is important for all of us. That's covered for another 2 years. In that time period from March 2020, using data from March 2020 through January 2025, there's a lot of policies that still need to be figured out. And there are some mandated reports that this bill includes that asks government organizations to look at the impact of telehealth access, costs, and quality as they're making final decisions on some of these policies. And so what are the policies that need to be, where there are still decisions that need to be made? So the biggest policy, not all of them, but the biggest policies are listed here. Including those geographic restrictions that I mentioned, telehealth across state lines, coverage for audio only or those phone calls, payment rates, the impact on healthcare spending needs to be figured out, and also what types of technology should be covered. And so as we move from March 2020 to January 2025, virtual care could look very different depending on how these policies are worked out in the meantime. And so for the rest of this talk, what I'm going to do is walk through each one of these policies, and I'll talk about what it was like before the pandemic. I'll talk about what it was during the public health emergency. And then I'll give you my prediction based on some data. In some of these cases, we have data from our lab. I'll give you my prediction on what it's going to look like in 2025. So we'll start off with geographic restrictions. So this is the most basic one. So as I mentioned earlier, telehealth was really meant to benefit rural patients. It was to help rural access to care in areas that have health professional shortage areas. And so because of that, the originating site requirement, the geographic restriction was there, and patients had to travel to a medical facility in a rural area to participate in telehealth. But during the public health emergency, geographic restrictions were removed, and then both urban and rural patients were allowed to perform telehealth from home. And so the big policy question out there is, how did removal of the geographic restrictions actually impact rural care? How did it impact the original intent of the policy? And so I'm sorry, and just as a definition, I'm going to keep using the term PHE. And so PHE essentially means the public health emergency. And the reason I'm using that term is because that's the policy that is tied to all these regulations that I'm referring to. So I'll call it the PHE. So how did the removal of the geographic restrictions impact rural access to care? And actually what we find is that in some of the data that we have, this is data from a report that we're writing for the state of Michigan, Telehealth in Michigan, data to inform policymaking. The removal of the geographic restrictions actually led to increased levels of telehealth, even in urban areas. And so these are 3 maps that you see in front of you. On the left-hand side is a map of the state of Michigan. Any area that's colored green is an area that's considered rural Michigan. And so if you go to the map in the middle, this is 2019. This is the distribution of telehealth in 2019 when those geographic restrictions were in place. So there's 2 takeaways from this heat map. Number one is that the distribution was primarily rural, as you can see in that map. And then number 2, the levels were still very low. So the levels on this heat map are number of telehealth encounters per 1,000 Medicare beneficiaries. This is, again, Medicare data. And so when you look at 2021, 2 years later, you see the distribution has changed. Actually, the majority of telehealth that's being done, even after you adjust for the population, is done in urban areas, not necessarily in rural areas. But if you compare the lowest levels in rural areas, for example, the Upper Peninsula here in Michigan, you see that it's still 10 times what it was prior to the pandemic when there was these restrictions that were there just to benefit rural patients. So the removal of the restriction made telehealth grow. It did grow more concentrated in urban areas, but there was a massive spillover effect in rural areas too. So my prediction for 2025 around this rule is that geographic restrictions will be permanently removed. I have no doubt about that. You'll be able to connect from home no matter where that patient is located. There's bipartisan support for that. In fact, recently, I think last week, there was a bill introduced in the House related to this. So I have no worries that this geographic restriction is going to come back. So the next topic related to geography is telehealth across state lines. And so prior to the pandemic, telehealth across state lines, and I'll use the term interstate telehealth because that's what that is called, is still governed at the state level. And so what that means is that each state regulates medical licensing, and they get to decide whether or not out-of-state clinicians can provide care with their patients in the state. And so medical licensure rules require patients to be in the state where the clinician is located. So it's not necessarily where the clinician is, it's the state that the clinician is located in and where the patient is located in. So during the public health emergency, all 50 states and DC independently relaxed licensure rules to allow interstate telehealth. You needed to. And then by December 2022, only 9 states still have these telehealth licensure flexibilities in place. Connecticut is not one of them, neither is Michigan. But these rules were independently taken off from 2020 up until now. And again, a lot of these were tied to the states, not the national public health emergency, but the states' states public health emergency, and those public health emergencies slowly, one by one, expired, and so did these licensure rule waivers. So the big policy question really it's at the federal level, but it's really at the state level, is what states should prioritize policies to enable interstate telehealth? And then what type of patients use interstate telehealth? So we do have some data on this that I'd like to go over. This is actually, we probably have the most data on this area because it's a topic that I'm very passionate about. So we did do a study. At the time we did this study, there was actually no data on this at a national level at all. So a lot of the conversations were based on narratives and anecdotes, but we did want to put some data out there so that it could help inform the conversation here. And so we published a study in a journal called Health Affairs about the trends in interstate telehealth use among Medicare beneficiaries. And so in order to do that, we came up with these 4 groups of healthcare encounters. There's out-of-state encounters that can be done through in-person or telehealth. And then there was in-state encounters, and those could be done in person and in telehealth. And I can get into the methodology and the definitions up later if anyone's interested. But ultimately, this is what we found. And so number one of the big findings in the paper was that out-of-state telehealth was really just a small portion of total outpatient visits. So at a national level, maybe it was like over exaggerated in terms of how much of this was happening. So this is this graph shows the dominant blue bar in this graph. This is a time trend from 2017 to 2020. So 2020 was really the year where all the licensure waivers existed. So it was a wonderful natural experiment that we can use to see how did patients use interstate telehealth. And so the blue dominant bar here is, as you would expect, is in-state, in-person care. The yellow bar represents out-of-state, in-person care, so patients driving across state lines to get care. Near the tail end of this graph in 2020, you start seeing some red bars. So the red bar is when telehealth started to come into play. So this is in-state telehealth is red, and that small sliver of green is out-of-state telehealth. So from 2017 to 2019, less than 1% of healthcare encounters were out-of-state telehealth. And then in 2020, it was still a low number, 0.8% of healthcare encounters were out-of-state telehealth. So overall, at a national level, this is a small percentage of care, but at a state level, and this is really where the story is that for some states, interstate telehealth care, interstate care is essential. So there's 2 pieces of information that you see on this graph here. This is a state level analysis. So all the states are listed here, and each state has a bar and a line graph associated with it. So the line graph represents out-of-state telehealth, that small percentage. For about 40 states, it's less than 2%. But that black or the blue bar is actually what I think is most important. This is out-of-state in-person care and telehealth care together, so interstate care. And so this really represents the opportunity, the ceiling that telehealth has the potential for. And so for states like DC, small landmass, you can imagine 45% of patients are getting care from Maryland or Virginia or states that are nearby. And then there's 10 states that have over 10% of their care is done across state lines, and for a variety of reasons. It may be because of a small landmass, or maybe because they're a state that's largely rural with healthcare professional shortages like Wyoming and South Dakota that you see listed there. For Connecticut, it was about 5%. We were right there with you in Michigan, right next to you. And so maybe less of a priority for some states, but certainly on states on one end of the spectrum, it's a big deal. The other big question out there is that, well, if you allow people to do telehealth across state lines, isn't, Cleveland Clinic and Mayo and other centers just going to take all of our patients? So is this being used for second opinions, or is this really being used just for established care? And what we found was that the majority of care was actually established routine care providers that they were driving across state lines to see, and then and trying to keep care stable with those providers. So the majority of care was actually for routine care, and it was a small percentage of new patient visits. So I do summarize this in another study that came after ours in this article or editorial in JAMA Health Forum. But ultimately, the data on this shows that the prevalence is low, but it matters for certain states. And then it's often used for ongoing care. And what I didn't show is that a large portion of interstate telehealth is actually with neighboring states. So 60% of the care is with states that are nearby. One of my colleagues who did another study on this later showed that 60% of visits were actually with patients that lived about 15 miles from the border. So it's really a border issue, and it's also a rural issue as well. And so my prediction for 2025 is that, unfortunately, this issue is not going to be worked out by then. This issue is way too complex to be resolved by 2025. I have a lot of experience with this, with groups that are in our institution that want to do virtual care across state lines, and it goes beyond medical licensing. It goes to insurance, malpractice, and so forth. So at this time, I don't think that issue is going to be resolved. It's hard to come up with a national federal solution, so it will have to be a state solution, which makes it a lot more complex. So I'm going to switch gears and start talking about more on the payment side. And so I wanted to see if there was any questions or anything that I could go through with what I've already talked about. All right, great. So I'll just I'll keep going for now. But you, of course, feel free to interrupt if there's anything that does come up. So the next topic that we're going to talk about is phone calls. So it's called audio-only telehealth, essentially a phone call. Medicare has always taken the stance that they're not going to cover phone calls. So if you call a patient, you're supposed to be calling patients with results. If you call a patient, you can't submit a bill for it. They were always worried that for some reason there's this narrative that doctors, we all have the time to sit here and just call patients all day and run up billing, which is just not, it's just not true. So they never wanted to cover phone calls. And then during the public health emergency, they actually had to cover phone calls. And it was for practical reasons. Number one, they said, okay, fine. Everyone needs to be doing social distancing and remote care, and we'll cover video visits. But then American Medical Association, AUA, and a lot of other organizations pushed back, and they said, well, not everyone can do video visits. So there's patients that can't do video visits. And then on top of that, when you call and talk, when you set up a video visit with the patient and they can't connect at that moment, what are you going to do? You're going to call them and complete the care that they needed. So then you all of a sudden you go from a non-billable visit, a billable visit to a non-billable visit, even though you're delivering the exact same content. Just didn't make sense. So then Medicare did cover phone calls, and they covered them during the public health emergency, which is now essentially at the same rate as in-person visits. They have a crosswalk for that. So the big question is going to be what's going to happen after that, after these rules are over. What's going to happen in 2025? Should phone call coverage continue? And then what are the unintended consequences of ending phone call coverage? So this was a study that we did early on in the pandemic. And after this study, there's actually been quite a few more that have validated the same thing that we found, which is that vulnerable populations will be impacted by ending audio-only telehealth coverage. And that's a fact, and that's true, and it's been shown in multiple studies. And so most of my studies are in Medicare data sets, but this one we actually did as a single institution study, and there were some advantages to that. Number one was that our time period, April through June 2020, this was an important time period. We were all very scared of the pandemic. And during this time period, there was a strong desire for keeping patients at home. So unless you absolutely needed to come in, your option was either doing a video visit, and our system was pretty well equipped for those, or doing a phone call. And those patients that chose a phone call weren't doing it because they felt like they were getting better care over the phone. They were doing it because they didn't have the means to do otherwise. So, and you can't replicate this time period because now these patients that would otherwise choose a phone call are just coming in if they can't do a video visit. So that was important. The other important thing about this data set is that we did have a connection variable that allowed us to know whether the video visit occurred. So it didn't matter how it was scheduled. It didn't matter how it was billed. We knew whether or not it was actually a video visit. So that helped us understand this issue of who can do virtual care video visits and who has, and where are there factors that may lead to trouble. And so we grouped patients into video users and phone users for this study, and we looked at the proportion of video users and phone users for a number of different demographics. And one of the most striking demographics was age. And so that's what you see here on this graph. The black bars represent the proportion of patients at that age bracket that was a phone user, so exclusively used phone, versus those that were video users. And you can see as you go up in age, there's an obvious stepwise association here where there are a greater number of exclusively phone users than there are video users as you go up in age. And so at around age 65, it's a pretty big deal. It's about 50 to 60% of patients were exclusively phone users during this time. Again, a unique time period because those patients are now coming in. And we also ran a model and we found there was a decreased probability of using video if you were African-American, you needed an interpreter, had Medicaid, and Medicaid was covering video, but still decreased the chances of using video, and then also lived in an area that had low broadband access. But one of the things I was most proud of and unique in this study was that we just didn't treat every individual patient as a single factor. In fact, patients actually have could have multiple factors that impact their what's called the predicted probability of using video. And so this illustrates that example. And so 3 different cases here. If you're young, not on Medicaid, no interpreter needed, 90% chance you're going to use video during that time period. If you added on the fact that you're over 65 and on Medicaid, that dropped to 37%. And then if you added the fact that you needed an interpreter, we had virtual interpreters, but if you needed an interpreter, that factor itself led to about a predicted probability of 19% that you would use video for your healthcare needs during this time period. So this is important. And ultimately, my prediction for 2025 is that phone call coverage will continue. The optics of taking that away are too bad. And so I don't think that it's going to go away, but it could be reimbursed at a lower rates. Now, they did lift the values of these phone calls up during the public health emergency to encourage it, but there is a chance that they could go down. And, the reason I believe this is because narrative tends to win sometimes more than data, and stories tend to win policy more than data. And it's really hard to explain to someone why it's not cheaper to just do a phone call. Because everyone I talk to, whenever we're talking about this subject, they're like, yeah, but you're just calling the patient. There's like no cost associated with that. But I try to explain, and it ends up becoming complex. And I try to explain, well, we're delivering the same medical content. We still have our nurses. If I order labs, I still have to follow up on those labs. We have our clerical staff that schedule that phone call and so forth. We still need to keep our brick and mortar clinic, funded, or we still need to pay the bills on that. And that's a complex argument. The simple argument is a phone call is cheap, so we should pay less for it. So unfortunately, I do think that reimbursement will drop for better or worse. And so that segues really nice into the next topic that we'll talk about, which is payment rates. And so what will happen to payment rates after 2025? So before the public health emergency, clinicians who performed a telehealth visit, at least for Medicare patients, received a similar payment to in-person, but they were given less, $25 less. And so $25 was called the originating site fee, which is basically $25 went to that medical facility that patients had to travel to. And so it was $25 less for those visits. But during the public health emergency, even though patients were connecting from home and there wasn't that medical facility, they felt the need to have payment parity or pay equal amounts. And so that $25 was given back to the healthcare provider that was conducting the visit. But there's constant debate about whether payments should be equal. Should telehealth visits, in-person visits, and video visits be paid equally? And like, where does audio only fit into this? And so unfortunately, I don't have any data on this. If you're interested in this topic, I did write an editorial that really lays out the case for telehealth payment parity, because narrative is really driving all of this. But there is an insufficient amount of data that exists on the true expenses associated with providing telehealth services. And there's this huge concern about fraud and abuse if you pay the same amount, but there are existing E&M billing guidelines that help to mitigate the potential for abuse. If you're familiar with the E&M billing guidelines, you'll know that there's certain factors that are built into this so that you can't just contact patients constantly and call them and bill for them. So, and also I truly believe the utilization of whether you're using video or audio really doesn't have much to do with the content of that visit. It actually has to do with the patient's capabilities or what happened during that visit if the visit dropped and you had to pick up and call them. And so that's really what's more important, and that's what we should be focusing on. But I think without sufficient evidence, the removal of payment parity will certainly discourage providers from offering telehealth to patients, and it'll take away this important form of technology. So my prediction for 2025 is that for Medicare payment rates, it's not a great prediction because it's basically saying it could be one or the other, but Medicare payment rates will either stay the same. It hasn't been, even though there's debate about it, there hasn't been any sort of proposals to drop rates right now. And then, or they could sneakily return to how it was before the public health emergency, because if they just sort of take away that $25 with the justification that if patients connecting from home, you don't need to give that extra money to another facility, that then it may actually drop. But that $25 for a level 3 visit is about 40%. So it is pretty significant and it adds up. I mean, if you think about specialties like psychiatry, where 85% of the care is virtual, that's a big deal. So we're still keeping an eye out for this, but I'm not sure exactly where that's going to go. So, and this kind of ties in really to healthcare spending. And so that's where the big question is. And this is what, even though when one of the telehealth bills that's similar to what ended up in the year-end spending bill just flew through the House, 416 votes yes, and about 16 votes no, bipartisan support, everyone likes it. That particular bill didn't make it past the Senate because we ran into the midterms, but the reason it flies through and why everyone likes it is because they know it helps. But the one worry that everyone has, and 416 congressmen had, was what's going to be the impact on healthcare spending. Congressional Budget Office, which gives a score to any bill that's out there, has always scored telehealth bills poorly because they believe that's going to increase spending. And so the idea is that telehealth is additive. It's not a substitute for care. So it's something you can do in addition to care, but it's not going to be a true substitute for care. And so that's how they've always scored it. And during the public health emergency, for-profit companies did not make it any better. There were a lot of high-profile busts for fraud by the Department of Justice for certain companies that were just basically designed to commit fraud with Medicare patients. And so those kind of things, those are the ones that hit the news. So people start to equate telehealth and fraud together. And so, but at the end of the day, even if you're not distracted by that, permanent telehealth policies are really going to be hindered by the concern of healthcare spending. And so that's the biggest question that's out there. Does telehealth lead to higher healthcare spending? And, I'm not going to give you an answer to that, but I will show some of the data that we have, which is actually arguing the opposite. And so this is a slide that I showed earlier. I told you that we're tracking Medicare trends. One line that I didn't draw any attention to, but I want to draw attention to right now is this dotted line that you see at the top. And this is the total number or the median number of monthly outpatient services that were rendered in 2019. So I drew that line all the way across to see if anything that happened in 2020 and in 2021 surpassed the volume of what we had in 2020 and 2019. And we don't see that happening. So even though 10% of care is telehealth, telehealth plus in-person care together is still not exceeding 2019 levels. Now I'm going to put a big asterisk there because I do know that a lot of patients were moving away from Medicare to Medicare Advantage plans. So the overall volume of services probably went down, but we did do this on a per capita basis, and we saw very, very similar results. And so ultimately, it is not increasing healthcare spending. And in my view, this is what I would call a substitution, not an additive service. But there is this possibility, and we are, I take an objective view when I'm studying healthcare policy related to telehealth. And so we want to find out the truth and not just make assumptions. And so this is a study that we published in Health Affairs where we looked at telehealth and the impact on downstream visits. So the idea is that you have a visit with that telehealth care provider, and maybe that visit is insufficient. They couldn't listen to your lungs, they couldn't get a full exam. And so as a result, within 7 days, you're just seeing someone else. And so that's what I call a downstream visit. And so we looked at symptoms of upper respiratory infection and patients that were seeing telehealth care providers, and then we found this matched control of patients that saw in person for the exact same condition. And then we looked 7 days later to see what happened and if there were any follow-up visits for a condition that was very similar to the one that they were seen for. And so, sometimes they could be resolved. And if it's not resolved, it could be a second telemedicine visit, could be another office visit, could be an urgent care visit, or it can be a ER visit. And so using this model, we went to this data, and what we found is that there actually was a higher rate of secondary visits for the ones when the visit was initially done by telemedicine. And so that difference was about 4%. So 4% of visits that were originally done by telemedicine required a visit downstream. I'm sorry, it was 10%. The delta or the difference was 4%. And so 10% required a secondary visit as opposed to 6% that were done initially in person. Most of these visits you can see were in either a secondary office visit or a secondary telemedicine visit, but nevertheless, there was that 4%. So this is important, and this is within 7 days. And so the work that I'm doing right now, this is just preliminary data, but this is the big project that I'm working on right now, is actually creating a model that we can test out for every condition out there. And this is what we've done, is compared in-person to telehealth across 400 different conditions. The model allows us to test different conditions at a time. And this is putting together 30 conditions that have the highest follow-up rates within 30 days. So we've extended to about 30 days secondary visits. And what we found is that the difference between telehealth and in-person was very small. In fact, at least for these conditions, it actually favored telehealth. There's some conditions where it's obviously the opposite, but importantly, at a grander scale, this difference is very small, especially when you adjust, including after adjusting for factors like age, gender, and other things that may impact revisits within 30 days. So this is preliminary, but this is where we think we can make an impact on this conversation related to overall healthcare spending. We're also looking at imaging and tests that occur within 30 days, and the big question of actual expenditures within that 30 days too. And so my prediction, I don't have a great prediction for 2025 on what's going to happen with healthcare, but healthcare spending, what I could tell you is that right now, to date, there's no convincing data that telehealth leads to overall healthcare spending. And, and hopefully we get closer to the truth on this when we do more studies related to this. And finally, I'll just leave you with one last slide about technology. So in 2025, what's healthcare in terms of, or what's virtual care going to look like? Virtual care in 2025. This is a slide that I presented to our health system leaders. We've, over the last year, have put together a strategic plan for where we're going to use virtual care for the next 3 to 5 years. And this plan is not, and this conceptual model is not unique to University of Michigan. It's used by many academic medical centers. This is where digital health companies are investing their money. This is where payers are looking, because payers are also reversing these alternative virtual first models as well too. So in the outpatient care side, I'm sorry, there's a little background noise there. I'll try to talk over it. So on the outpatient side, there's video visits. That's what we're all familiar with. But for a lot of conditions, there's also this growth in what's called remote chronic management or remote patient monitoring, which is going to be a big part of healthcare delivery at a population level. when patients need to go to the emergency room, finding alternative ways to go to the emergency room, including virtual urgent care, and then ED triage. For patients that need to be hospitalized, could they actually not go to the hospital, but instead go home and get hospital level care at home? So this is actually a big initiative by the Medicare program that they're paying for. And a lot of people are getting behind, including our healthcare system, where we're diverting patients at home, giving them visiting nurses, community paramedics to go to the house if they need to, virtual visits with providers that are there, and nurses that are available for them. So that's called hospital care at home. And then even when you're in the hospital, I'm sure that your health system probably struggles with the exact same stuff that we do. And what for us, hospital congestion is a big deal. Patients weren't waiting in the emergency room just to get a hospital bed, which clogs up the emergency room. And so there's a big trend in inpatient virtual care too. And the biggest trend in inpatient virtual care is this concept called virtual inpatient nursing. And what that means is that like if you have a big backlog in 5C because there's a nurse called in sick or two nurses called in sick, and you can't get patients out of the hospital. So there's this downstream effect where because you can't discharge that patient, can't get a new one in. So what virtual inpatient nursing is that they can call for help, and then a nurse shows up on the screen and then does the entire discharge for that bedside nurse and tries to get that patient out of the hospital. This works for care management too. So that's a big trend that's occurring, virtual post-acute care. And of course, we have this statewide system that we want integrated with virtual care too. So this is, and like I said, this is the reality of where virtual care is going to fit in outside of the ambulatory care space, but across the entire continuum of care. And so I'm going to leave you with this quote. This is one of my favorite quotes because it really embodies the way that I think about technology as we're implementing it at the health system level, and then also as I think about it in objectively on the research side. So technology is capable of doing great things, but it doesn't want to do great things. It doesn't want anything. That part takes all of us. So thank you again for your time this morning. And I think we got about 20 minutes or so. So I'm happy to answer any questions that you may have or dig deeper in any topic that you'd like to.
Chad, this is Michael Lietman. I'm a urologist at Yale. It's a phenomenal talk. Thank you so much. I was wondering if you could say a bit more about, optimizing physician performance in the virtual world and transitioning. There seem to be people who are just, maybe better than others at transitioning. What are the attributes? What are the strategies? Is there work looking at strategies to be more effective in the transition? In terms of documentation.
Yeah, sure. And so, when you say transition, do you mean sort of like integrating virtual care into the daily clinic schedule, or transitioning between virtual and in person, or?
Yeah, that's a great. I think both, really, right? Yeah. I mean, I think maybe it's not a full not a full shift, but in adapting someone who's been in practice for 30 years in person and has that down a lot to moving to the screen. And you're right, and transitioning like one visit in person, how best to use that time to use that virtual certainly. That virtual visit
And I could talk about both of those topics. So number one, and I've obviously had to deal with this a lot in terms of like trying to encourage providers to do virtual care. When we looked across our department, there were some providers like our stone providers and our oncology providers that were about 50% virtual, actually 30 to 50% virtual that they were in there in that window. And then there's other providers that were as low as 3% or 0%. And so I spent a lot of time trying to encourage providers to do virtual care, do more virtual care, find out why you can't do virtual care and try to enable it. And then at a certain point, I started to think, why? Like, why am I doing this? This physician has this robust in-person practice, and I could build in 12 more virtual slots into their practice, but that's going to impact their in-person care. And so then we started to think about, where does virtual care fit in to our overall clinic or overall goals of our department? And one of the big goals of our department is access to care. And so if you end up having unfilled virtual slots, and as a result, in-person slots patients have to get are pushed out further for in-person care, then there's a demand and supply mismatch. And it's really hard to say, do more virtual when your new patients are getting booked out a month out. So I think one of the most fundamental thing that, and this occurs at like a leadership level, is to sort of understand the principles of why you want to use virtual care. And I think one of those principles has to be matching demand and supply. So if, on the other hand, if there was a lot of patients that are saying they want to get in virtually, but they can't get in virtually, then obviously then that there's a bigger conversation that needs to happen about increasing virtual slots. But I think it's important to actually match demand and supply for this particular issue. And but fundamentally, I also believe that not knowing how to do virtual care is not a good excuse for not offering it. So if there's a demand and supply issue, that's one thing. But I think every provider should know how to do virtual care and offer it, because sometimes I would hear the argument that like, oh, my patients want to see me in person. I'm like, you sure? 100% of your patients want to take the day off for you to talk to them for 15 minutes. That's pretty paternalistic. So I think that you should have the ability to do it, but you may not necessarily need to do it at a very high level, especially if your in-person demand is exceeding your virtual demand. So that's what I would talk about in terms of encouraging providers, is really figuring out that perfect number, or that demand supply mismatch, which can actually be calculated. And then the other thing is, for providers that are interested in virtual care, integrating it into their workflow. I actually think that there's kind of two big things to think about. Number one is to create blocks of virtual care. In my own practice, it's been very difficult to do in-person and then switch to virtual and then do in-person, because when a patient is waiting 10 minutes or 20 minutes for you in clinic, they know they've just got their vitals checked. You're around the corner, you're going to be in there. When they're waiting 10 to 20 minutes for you on a virtual visit, they think they've done something wrong. They're calling your call center and so forth. So I think that it's really important to stay efficient when you're doing the virtual visits. And the only way to do that is having block scheduling. So along with block scheduling comes the opportunity to actually change some of the dynamics in clinics. So if you're doing block scheduling, that provider may not need to necessarily do the visits from there. Maybe they should do them from there if they're having trouble connecting, and then there's people around that can help. But otherwise, doing them from home or doing them from a different facility actually frees up a half day or full day session in clinic where another provider could come in, or you can use those rooms more effectively for the providers that are there. So I think those are some of the small workflow things that could help with the transition between virtual and in person.
Chad, this is Isaac Kim. Thank you for your talk. This is a very enlightening. So I got two questions. So you alluded, I just will follow up on what you just responded to, Michael Liebman's question. You said the ideal breakdown between in-person and telemedicine visit can be calculated. How do you get around it, arrive at the number?
Yeah, I'm sorry. I can rephrase that. For people that have integrated virtual care into their practice, you can look at the schedules and figure out what's being filled and what's not being filled. That's actually what I meant. So like simply looking at the schedules, like I'll give you an example. There was a physician assistant in our institution that really liked doing virtual. And as I'm answering this question, I'm going to answer the question in the chat too, so she was doing virtual visits from home, which was a great improvement in quality of life. You could do visits from home, and people like to do that. And so that was great. And so she had about 4 days that was virtual, and then 1 day that was in person. But that was a big demand and supply mismatch. And so what we'd find is that on days that she had virtual, maybe part of the reason that it's such a nice day is that there was only 4 or 5 patients scheduled. And then on the days that she was in person, not only was the schedule filled, but patients couldn't get in person. They were getting booked out 3 to 4 weeks. That was a bad demand and supply mismatch. And so that was an extreme example, but others have that too. And some people you can see it. If you look at scheduling grids, you can sort of calculate it that way, but it's not predicting it. It's more about looking at what's being filled and what's not being filled. So looking retrospectively.
Gotcha. And then it's a follow-up. So again, your earlier data about the secondary visits and the equivalent between the in-person visits, telemedicine visits. So that's more on the economic impact, let's say, for this. Are there any data about are there any data about the quality of the visits, let's say, or quality of the outcomes? So for those visits, if that secondary visit in fact is necessary and you forego or not done appropriately, then the outcomes may be impacted. So is there any sort of data out there about the impact, the outcomes impact from telemedicine visits?
Yeah, I mean, there certainly is outcomes. There are people that are looking at quality and also, since virtual care isn't new, it's been around for a long time. There have actually been a lot of, randomized clinical trials and so forth prior to pandemic that have looked at quality of care for in-person versus virtual. And so it's hard for me to summarize that because, it's all, as you would expect, it's mixed. For some conditions, you can see no difference in quality, which is really the kind of like the non-inferior is really what I think the goal should be. But, and in some areas you may see quality differences. So I can't summarize it on our level. Where I look at, I specialize in Medicare analyses. We are, as part of our grant funding, we are looking at quality, and to the extent that you trust kind of Medicare quality measures. So we're looking at things like 30-day readmissions and so forth for practices that use telehealth and seeing if there's a difference when telehealth is encountered. So we are looking at quality, as you know, as well as I do. Quality is a complex way to define it, but I do think it's on the radar of everyone. And whenever healthcare policymakers are, when they're talking about this data, what they want is impact on cost, access, and quality. And so that's a big part of what is going to be continue to be looked at.
Got it. Thank you.
That was a great talk. You answered a lot of questions that we're curious about. One of the things you said is that the omnibus bill goes to 2025, giving parity for phone calls and other telehealth visits. I might be wrong, but my understanding is that for telephone visits, there are 3 levels that Epic recognizes, mostly by time. So how is there equality between the two? How does that crossover work?
Yeah, it sort of depends on how your how your system has set up the billing, but you're right. There are for the Medicare program, there are 3 different levels, and it is based on time. So the way that we do it is that you kind of put in your office billing level, and then they look at that time equivalent and then come up with a crosswalk that goes into one of those 3 buckets. But what Medicare has done, when I say that they're paying at parity, means that they look at those time intervals and then they found office billing levels and then they've matched those. So like, I can't remember off the top of my head, but an example would be like the middle billing code is crosswalked to the level 3 office visit code in terms of value. So that's how they pay for parity. So it's not the same. I mean, you can, you can point that out right away, is that, if you're doing a level 5 visit, high complexity in the office, then there's no phone call equivalent for that. So it is compressed into a crosswalk that fits into 3 categories. There's a question in the chat here. Are there any data regarding the impact of cost for transportation for office visits and specialized needs that would need help support the use of virtual care? Yeah, there have been, and actually there were studies. There was one from Matt Getman out of Mayo prior to the pandemic, and a lot of people have looked at the cost of transportation, and that plays into the patient cost. And of course, at our system we look at miles saved, and that's a good metric that is often used in advocacy. So miles saved, cost of transportation, cost of parking, and opportunity cost for the patient. So the ones that don't have to take off work to do virtual care. So those are all absolutely considered in the equation. I think there's actually a robust, number of studies that have looked at transportation costs. But what policymakers are still looking at is like, what's the bottom line impact on overall healthcare spending, which the patient part is extremely important, but that's a different economic issue.
Chad, Michael Lietman here again. Just one follow-up question. I dropped off for a bit, so I don't know if you got to it, but have you looked at, the proportion of telehealth visits that get a subsequent in-person follow-up? I think this happens a lot for me, is that, we get into something on telehealth, we realize we're talking about a complex operation. We want to have the discussion up front. So, in an aggregate level, that might not add a lot, that's an extra visit. and maybe it's a drop in the bucket for a complex episode of care. But I'm just curious if that redundancy has been looked into.
Yeah, it is. We're kind of in the process of looking at that. And so one of my last slides was related to the study that we're doing right now across many different conditions, is looking at follow-up visits within 30 days. And the reason we're looking at, we published a study on 7 days for acute respiratory, but the reason we're looking at 30 days is exactly that clinical scenario that you mentioned, and it's exactly what we see. It resonates so well with me that, you know, you're seeing a patient and, you know, you're almost there, but they kind of need a PVR, or, you know, you're seeing them for infertility, they need a scrotal ultrasound. So like you kind of, or you have to do a physical exam. So you're almost there, but you just need to see them again. And I think that scenario resonates pretty well. So that's exactly what we're looking at right now, is secondary visits, secondary imaging, secondary labs. So I don't have the answer for you right now, but
and maybe, I mean, even if there is redundancy, I mean, maybe that's okay, right? Because maybe you are providing a higher level of care by triaging that, and not everyone gets to that point.
Yeah, 100%. And I think 100%. And I think for oncology providers, like sometimes when they do a visit, they don't have all the imaging and other things that they need to make a decision. But that initial visit can help reassure the patient, give them a general plan, and they can follow up later with physical exam and the imaging to give them a final plan. And again, at an aggregate level, it may be a small part of this, but I think that at the individual level, you know, it may be higher quality care, and we don't have the right answer for that, or we don't have a definitive answer for that right now. So like, I mean, one good example is patients that are seen for hematuria. So I actually, you know, we do, for a while, there's, you know, kind of mix of practices. You know, some people will do same-day cystoscopies, but then what was happening is that a lot of these same-day cystoscopies had to be written off because patients actually didn't have insurance authorization to do the cystoscopy and so forth. There was all these complexities that are discouraging same-day cystoscopy. I think a in-person evaluation for microhematuria, you know, is not necessary. I mean, you could, if you were going to see a person and then you're going to do a cystoscopy on that day, you could do a physical exam on that patient, having a virtual visit where you discuss what you're doing and ordering the CT and so forth. And then you have a follow-up visit where you're doing the cystoscopy, doing a physical exam and reviewing the imaging may actually be much more efficient care for the patient.
I think a ripe area for research that maybe you guys are doing is that medical legal actions sometimes lag care because it takes a while for the damages to be noted, and then the legal process takes a long time. Now from 2020, that data might be maturing. I think that most cases when it comes to office visit relate to delaying diagnosis, delaying treatment. I wonder if you or other groups have looked at that.
We haven't looked at that, but I do agree with you. That's extremely important for us to look at. And I 100% agree with what you just said, which is that this is something that is probably not front and center because there is a lag time with the whole legal process, but I think it's something that needs to be encouraged. And one thing I pushed the AUA on and the task force is that one big thing that we need out there, and I'm thinking of maybe writing an editorial in AUA News or JU about this, is that we need to refine our guidelines to help give practices guidelines on when it's okay to use telemedicine. And what I would actually suggest is that all of our guidelines have like a paragraph on where we think it's okay to use telemedicine. And the reason for that is because, and first of all, you know, as all of us are aware, a lot of our guidelines are based on expert opinion and clinical principle, as opposed to, you know, tons and tons of randomized controlled trials. So like, I think that, you know, I think it's reasonable and appropriate for us to have an expert opinion or clinical principle related to telemedicine, particularly because as the growth of telemedicine grows, and if there are legal actions that occur, you know, you can go to the guidelines and say, well, you know, your guidelines say nothing about using telemedicine for this condition. You were supposed to bring them in for a physical exam and so forth. So I think as healthcare is modernizing, we need to modernize our guidelines to sort of match clinical practice and principles that we're following in practice. Great. I think we're at 8:30. I'm more than happy to share my email if there's any follow-up questions that anyone has. But I do really appreciate the time to come talk to you, and it was an honor to be here.
Yeah, thank you so much for visiting our department. Have a great day.